We've been focusing on patient assessment in this module. The why, how, and what to do have all been addressed, but we haven't really talked about the what not to do. In this segment, we're going to focus on a particular problem in society, something that many of us will bring into the field, something that if not recognized and addressed will worsen with the things we'll experience in EMS. Bias and stigma. Here's a story to illustrate the point. This really happened. During an ER clinical shift, a student and an instructor walked into a patient's room to practice an assessment. The patient was a mid-40s-year-old Caucasian male, obviously disheveled, not well-groomed. His clothes appeared to have been worn for days, maybe even weeks. He reported to be homeless. He came in with left shoulder pain after being struck by a car a week earlier in an auto pedestrian accident. Although in the ER for only about half an hour, the hospital was already working on discharge paperwork. The student began her assessment. She determined there was no obvious outward signs of trauma to the shoulder. He had good range of motion, strong distal circulation. So not based on the patient's complaint, but rather the mechanism of injury, she decided to check the rest of the body. Head, nothing significant. Chest, unremarkable. But as she moved to the abdomen, she found tenderness and a slightly palpable mass to the left mid to upper region. She was doing great. But then something unexpected happened. The patient burst into tears, not because of any discomfort caused by the assessment, but it was clearly emotional in nature. The student appropriately asked if there was anything she could do. As the patient began telling his story, both the student and the instructor were horrified at the details. A week earlier, the patient was on a downtown street corner when a car, driven by a woman apparently not paying attention, jumped the curb, striking him and then moving into the intersection where she hit another car. She became instantaneously and inconsolably hysterical, while the driver of the second car was obviously angry. Naturally, 911 was called. Upon arrival, emergency providers began trying to defuse the chaotic scene, focusing primarily on the occupants of both vehicles. The patient, our patient, the one currently in the emergency room, approached law enforcement, informing them that he was first hit by the car. He was quickly dismissed and told to move away from the scene. As he watched from a distance, clearly confused, he made the decision to approach once more, this time to EMS. Again, he was blatantly rejected. This time he persisted, leading police officers to tell him that if he continued to disrupt the emergency response operation, he'd be arrested. It's worth noting that aside from the auto pedestrian aspect, this two-car collision was not a significant impact. The patient left the scene only later to have developed the shoulder pain. Eventually, as it worsened, he made the decision to walk to the hospital. This was a week later, and it brings us back to the story's beginning. He explained that he became emotional because this was the first time in the entire week's events anyone had bothered to listen to him or perform any kind of an assessment on him. No one even laid a hand on him. Afterwards, the instructor and the students relayed their assessment findings to the ER physician, who reluctantly ordered a CT of the patient's abdomen. The results showed an encapsulated splenic bleed. His spleen was slowly being destroyed from the inside out. His shoulder pain was due to a not-so-uncommon phenomenon known as Kerr sign, or referral of pain due to injury to the spleen, which was later removed. I preface this story with, "This really happened," because otherwise it sounds anecdotal. But what if I were to tell you this happened all the time? The homeless, drug-addicted, mentally ill are all susceptible to stigma. Here's another story from an actual provider who didn't realize his own bias until much later, about a year after the call. So, Drew, thanks for being on with us. I understand that you have a story that you want to share with us concerning your experience with stigma and a patient encounter. Before we get into that, you want to just tell us a little bit about yourself?
Absolutely. My name is Andrew Hoffman. I'm a flight paramedic. I was on a pretty busy service on an ambulance for about 5 years, and then switched over to flight, and have been in flight over the last 2 years. So a little over 2 years now, I guess.
Okay. Well, as you know, we're talking about patient assessment specifically and how stigma actually plays a part in that. And so I understand you have a story you want to share with us.
Absolutely. Yeah. I was about 3 years in the field. And at that point, when I was the most dangerous you can be, where I was starting to relax and be very confident in my skills. And of course, like I said, just making making me a very dangerous paramedic. And so we were activated one night, a little after midnight, for a 30-year-old female with chest pain. And so we arrive on scene, and right away I started. I'm tired, first of all, after running calls all day, and so right away I could see that this wasn't a critical cardiac patient. Just from the door, I'm thinking, not the standard presentation. So um, started an assessment, ran a 12 lead on her, found no anomalies in the 12 lead, did my cardiac assessment, and she was really not tripping any of the red flags. And so, kind of expecting that this would be a refusal, I started to talk to her about anxiety and how it can mimic signs of cardiac distress. And but she was insisting she wanted to go to the hospital, and so I said, "Sure, that's my job. We're going to go to the hospital." So I take her to the hospital, totally uneventful, no problems, and that was about that. Well, it was about a year later. We're activated again, kind of in the middle of the night, for a 31-year-old female who has abdominal pain, and arrive on scene. Didn't immediately recognize the young lady, but it was the same lady, and she was pregnant, about 6, 7 months pregnant, and was having some abdominal pains, pretty standard. Again, nothing super critical. And it was about a third of the way into the call that I realized I recognized this lady. This was the lady I ran on about a year prior. And as I'm questioning her about her abdominal pain, and I started asking her about her medical history, she said, "Well, probably the most significant medical history I have is that I had a PE about a year ago." And all at once, the information kind of crashed together.
It's a pulmonary embolism.
That was exactly what she had suffered from, or at least that was the diagnosis she received at the emergency room after I dropped her off. And so there was about a 5 or 10 second moment where I was horrified that I realized that I had taken care of someone who was having a possibly an extremely dangerous problem, and I had just dismissed it as a young, anxious woman. And so I had seen, a dozen or so calls that were just like this lady's, where, middle of the night, a younger female who was just extremely anxious. And so it really, really made me rethink the calls that I had run, that I had experienced it more or less this same patient. It really hit me like a ton of bricks, though, when she said that she was diagnosed a year ago with this problem, that this was on my watch, that I had let this slide by, and that my assessment was not thorough enough, not even close.
And that can actually kill someone, right?
Oh, absolutely. It can kill someone in a way that even if you are in the best hospital in the United States, if you're having a bad enough pulmonary embolism, you're going to die, and that's just that. And so, and here, like I said, I had essentially a ticking time bomb on my hand, and I thought of it as an easy, no-brainer call. And it really, honestly, made me rethink the way that I treat a lot of patients who I think are just anxious. I'll file this under another anxiety call, and it was a real wake up for me, and it taught me quite a bit, actually.
Yeah, you bring up a good point. We talked about like the homeless and drug addictions, mental illness, but anxiety that has a certain stigma in the medical field as well, right?
It absolutely does. Yeah, it is. It honestly has an interesting effect on a lot of providers. I know the way it has an effect on me is that I get very stressed out when I have a mentally ill patient. So it can be really, really difficult when you're dealing with a mental health issue, for sure.
Yeah, I think this is a good story to bring up because in the case that I just gave a little while ago, there was a negative stigma towards a homeless man. There was a kind of belligerence towards him. But in this case here, you weren't acting like that. You were acting professional, from what I understand of this patient, but nonetheless, the assessment suffered.
Oh, absolutely. Absolutely. I was definitely being outwardly very professional, but I can be super honest and say inwardly, I immediately dismissed this patient as a non-critical anxiety patient. I snapped to it because I recognized immediately this patient that I'd had a dozen times before, and this one must be another one. And like I said, I was very nice to the young lady the entire trip, but inwardly I was thinking, this is just anxiety, so I don't need to have any alarm bells going off.
Well, Drew, I really appreciate this story. I think this helps a lot kind of paint the picture of how stigma and bias can actually affect patient assessment. And with patient assessment suffering, so can treatment of the patient as well. So I really appreciate you being on the show. Thanks a lot.
Oh, absolutely. I'm glad I could help.
These were just a couple of stories of how stigma and bias can have a negative impact on your patient assessment. Here's the conundrum. You will not find a paramedic who can honestly say it has never happened to him or her, myself included. No matter how much we stress it, it will happen to you. The most we can do is emphasize the point so you're better prepared to recognize it, either during its occurrence or afterwards, so that you can learn from it and minimize its frequency, ultimately becoming stronger in your practice. I hope you enjoyed it. Don't hesitate to reach out to your instructors with questions, and thanks for listening.